there's a lot more multiple choice. Yeah. Okay. So first thing we're going to go over is the knee. So what bones? Okay, so what bones make up?
What's your silly out here? Whoa.
Right? I walked in and thought straight.
Really weird.
Yeah, I couldn't walk straight.
Alright, Western Hall. I didn't read well.
Okay, so we're starting with the knee. I'm going to go fast because there's a lot of stuff to cover. But this is on learning sheet if you want to take notes on it or whatever. Okay, so what bones make up the knee joint?
Femur, tibia.
Yeah, femur, right? So tibia, fibula, patella, femur. So the ligaments. So what? I kind of get on the picture. So this is like a right leg, right? So you're going to have the medial collateral ligament, lateral collateral ligament, the ACL, the PCL, patella. Yeah, just know the bones, the ligaments, and then the joints. And stability in the knee is due to what? Yes, the ligaments. And then what's the screw home mechanism? Yeah. So when it goes full extension, your foot's going to slightly, or I guess not your foot, your tibia will slightly externally rotate so that it can help it be in full extension. So when you fully extend, if you like look at your leg, if you look at your leg, like your tibia will slightly externally rotate. It just helps with full extension. Okay, so ligaments. You have your MCL, ACL, or LCL, ACL, and PCL. So MCL helps prevent against valgus stress, and LCL helps prevent against varus stress. So those of you in Dr. Johnson's class will know this, but this helped me. So we have valgus and varus. So this is like, right, you have like a force on the medial side, so that's valgus, and then varus, it's going to be more force onto the lateral side, so that's varus. Does that make sense? Like if these are the legs. Yes, no. That helps me like remember, because I just like would draw it on a test. So I knew like, oh, okay, when it's talking about valgus, it means that there's going to be pressure on the medial side. So this is going to have to do with the MCL. And varus, there's going to be pressure on the lateral side. So this is going to have to do with the LCL. Yes? Okay. So ACL prevents anterior translation of the tibia on the femur. And then so it's going to prevent posterior translation of what?
The femur.
Yeah, the femur on the tibia. So be able to like recognize that anterior translation of the tibia on the femur also equals posterior translation of the femur on the tibia. And then the ACL, because it like crosses, it's going to limit valgus and varus stress. And then the PCL prevents posterior translation of the tibia on the femur, also anterior translation of the femur on the tibia. And then that's going to resist hyperextension. And so, if you see something that's hyperextended, you'll know, oh, injury to the PCL. And then remember how to test for ligament laxity. These are just the tests that you did in your assignment. So anterior drawer test, and then just know what names of those tests. I don't remember all of them. Posterior drawer test is that called? I just have it. But remember the names, that's also important. Any questions on this?
So the tests weren't in his like slides. So
Oh yeah, they should be in the book.
okay.
And then you did it for your assignment, so you should know on the assignment.
Okay.
You just have to, yeah. You don't have to know like all the tests, just know one for each test. Okay, so the menisci. So the function, they have a lot of functions, but the main one is to distribute load, absorb shock, and then decrease friction between the tibia and the femur. The lateral meniscus is smaller and it's more mobile. So the medial meniscus is going to be the one that gets injured more often. And then menisci are avascular, so it's really poor healing tissue. And it's mostly injured from compression and rotation of the femur on the tibia. So a lot
Did you
of...
say medial is injured more?
Yeah. Yeah, so when you're, usually it's like if you're planted and then you rotate with your foot still planted, that's going to cause some compression and rotation. And then the best way, people can feel a lock or they hear like a clicking, and the best way to diagnose it is getting an MRI.
What is that like clicking? Is that just the bone on bone when you move part of the cartilage, or how does that work?
So I think it tears, and then when it tears, like your bone just like rubs against it, so it locks. It causes the joint to lock. You can't move it. Has anyone torn their meniscus? Is it really?
I don't know.
Yeah, I mean, I also tore it with the ACL and MCL, so I wouldn't know the difference, but I'll just imagine that it was hurting a lot.
Yeah, I had a friend that broke his femur, and when he broke his femur, he also, I think he tore his ACL, but they were like, oh, your broken femur is more important than your torn ACL, so like didn't really acknowledge the problem anyway. It was great. He also fractured his cymatic bone. Anyways. Okay. So what you just talked about, the unhappy triad, is ACL, MCL, medial meniscus. So know what makes up the triad, and then what often injures it. Like I just said, your foot is in a fixed position, and then you have a lateral force that's going towards the medial side, like this image. Yeah, so be able to like look at a picture like this and say, oh, MCL is probably torn or something like that. He'll probably have an image, he said this in class, but he'll probably have an image of something like this happening, and you'll have to say what ligament or what was injured.
I have a question. If you had like a varus force, would you tear like the LCL and the ACL? Would that be a possibility?
Yes, but most likely it's just the LCL.
Okay.
So anything that's going to be like a valgus force, like this, it's probably safe, well, don't like quote me on this, but safe to say unhappy triad, like you can say, oh, these are probably all. But when you go lateral, you can say like there might be a possibility of an ACL injury, but mostly it's going to be focused on LCL. With his test, like if you give reasoning and like if you were to just say LCL and ACL, then maybe you would mark it wrong. But if you said like I know that ACL, like it also prevents valgus and varus stretch because of the way that it crosses over, then like we probably give you points for that. So if you can like justify it, unless it's just wrong and you're justifying the wrong answer, if it's like sort of on the fence, but then you justify it and it makes it right, then we'll probably give you points. Okay, so these are just other injuries that can occur on the knee. we already talked about, I didn't want to go over this because we already talked about quadriceps contusion, which can lead to myositis ossificans, which is, yes, ossification of the muscle, so muscle transfer. And then bursitis is pretty simple. It's just inflammation of the bursa. Can happen from like chronic overuse. Yeah. And then patellofemoral pain syndrome. You guys went over this in your assignment, so I'm not going to go into too much detail. But it's basically anterior knee pain, right? So you have chondromalacia patella, which is deterioration of the patella, softening of the patella. And then patellar tendonitis, so inflammation again. So go over your assignment answers. Okay. So some other ones that you talked about in class. IT band friction syndrome. So this is caused by chronic overuse, and it will lead to knee pain. And it's usually caused by friction between the IT band and the lateral femoral condyle. And causes are overpronated foot, tight IT band, genuvarum, which means like here bowlegged, and weak glutes.
Those are causes or symptoms?
These are causes. Yeah, so like symptom is going to be knee pain and like tightness in your IT band, and then causes pronated foot. Yeah, and I believe the management for this is mostly just stretching, strengthening the muscle. Okay, and then patella maltracking. So what is maltracking? Yeah, so it's when the patella moves around and it's not supposed to, right? So lateral tracking is most common, this lateral side. And just know some causes of maltracking. He listed a lot. I just put some that are easy to remember for me. So vastus lateralis and vastus medialis contractions that are offset. So those are neutralizers, right? Because they have the same action, but then one will also rotate laterally and rotate medially. And so if they're offset, then it will cause the patella to move. Excess fluid in the knee area, vastus medialis atrophy, high Q angle. Do you guys know what a Q angle is?
It's how like far the femur goes from your hip bone, right?
Can you draw it?
Yes. So the Q angle. I don't know. So the Q angle, like, I'm not that great at drawing, but let's see. The hips are like this. Sure, that looks like a foot, right? And then the femur is like that. So it's like this angle right here. So like how steep is this angle? Does that make sense? So like people with greater Q angle will have wider hips. So it'll be like that, and then the angle is larger. Does that make sense? So women, so it says what gender has the greater angle. Women tend to have a higher Q angle because they generally have wider hips for like birthing purposes and stuff like that. And so their femur, the top of their femur in relation to the bottom of the femur and the tibia, there's going to be a bigger angle right here than men.
So they suffer patella maltracting more often than men.
Probably, I would guess so. I don't think it says that specifically in the slides, but I would guess that yes.
Is it the angle at the hip or is it at the knee?
I think it's at the knee.
Yeah, So it's like, right, so like it's this angle right here. Does that make sense? Yeah. Yeah, so I know it's at the hip, but I'm confused what that is showing. That's kind of confusing. But just know that it's like how far the bottom is, or the superior and inferior. It's like this angle. I don't understand.
On like the inside of the hip is like what it's.
Mm-hmm. Yeah. So if you think about like women who have wider hips, then this angle right here is going to be bigger than guys who have not as wide hips. Yeah. So just like picture like women's hips are like this, and then men's hips are like that.
And do we have to remember like a definition for it, or just the principle of it?
No, just the principle. Yeah. It causes patella maltracking. You don't have to like really understand it in depth. Okay, and then tight IT band, pronated foot, those also cause patella maltracking. And then know the difference between subluxation and dislocation. We'll talk about this with the shoulder as well, but what's the difference?
It goes back in.
Subluxation comes back.
Yeah. So sublux just goes out, immediately comes back, and then dislocation, you have to get reduced by a professional. So that can happen with the patella as well. I think you had some pictures on the slide, they're super weird looking. Okay, so the shoulder.
You got a good one.
Yes.
I'm sorry, I had a question on the last slide. So just like, is it super important to understand why the patella tends to track laterally? I feel like we talked about that, but I just can't remember what the reason was for that.
Yeah, let's see.
Yeah, just so now, so.
I want to say that the lateral facet is larger, and so it has more room to move. I don't know if that's actually, but you don't have to.
The lateral facet is large.
Yeah. So,
Right.
I don't think you have to know that
Don't
in
worry,
depth.
they're saying don't worry about
Yeah. It's on the test though, don't.
it.
It could be on the test, so look it up. Okay, so the shoulder. Shoulder is more unstable, right? Because it's a ball and socket joint, so we have a lot of range of motion. And so a lot of injuries occur here. So the shoulder is made up of the glenohumeral joint and the shoulder girdle. So know the difference between those. The glenohumeral is just like the humerus and the glenoid fossa, and then the shoulder girdle is made up of the joints around it. So we have the AC joint, which is the acromioclavicular joint, sternoclavicular joint, and the coracoclavicular joint. And if you know the names of the bones, it's pretty simple where they are. So
And we also have to know like the scapulothoracic or what was that joint? There was some thoracic.
Oh yeah, you're right.
It's like sliding.
yes, that's the scapula. Yeah, the shoulder girdle. It's part of the shoulder girdle. Shoulder girdle, yes. But just know these main joints. And then the motions of the shoulder, you're going to have flexion, extension, abduction, adduction, and then internal and external rotation. Pretty simple, like basic anatomy here. Okay, so you have your static stabilizers, which are your ligaments, your labrum, and your capsule. So those are going to be when you're not moving, right? Ligaments don't really move a lot. If they're lax, that's what causes injury. So when you're not moving, ligaments, labrum, and capsule, those are your static stabilizers, and then dynamic stabilizers are your rotator cuff muscles. So rotator cuff muscles are going to be most important for shoulder stability, even more than the ligaments and stuff. So you have the subscapularis, the supraspinatus, infraspinatus, and teres minor. They all originate on the scapula and insert on the humeral head. So be able to label its picture. So where is anterior and where is posterior? Yeah, so this is the anterior side, and this is the posterior side. And then know, like, if you know that this is anterior and posterior, then it's pretty easy to label these muscles.
How do you know which is which, anterior versus posterior?
So, I mean, if you think about like this is gonna fit into here, the glenoid fossa, right? And then you have there's like a tubercle right here. So that's gonna be on does that make sense? Yeah. Okay. So if this is the posterior side, then what is this muscle? Yeah. Teres minor, infraspinatus, supraspinatus is on top, and then subscapularis. Okay, and then this is just a picture of the rotator cuff muscles. So anteriorly, you have subscapularis. So just know the muscles and what basic actions they're most in charge of. So what is subscapularis going to be in charge of? Internal rotation, right? So this is the anterior view. So if it's gonna pull this way, it's gonna be internal rotation. And then supraspinatus,
Abduction.
yeah, is going to be abduction, and then infraspinatus and teres minor.
Wait, adduction or abduction?
AB.
Yeah, abduction. And then infraspinatus and teres minor, they're going to do like external rotation, probably some adduction as well.
They don't do any of the, I mean, deltoid does the flexion and extension. They're used to doing that.
But they're not good balance. Yeah. Cool.
Okay, so now we're going to injuries. Clavicle fracture is most likely to happen in the middle 1/3 of clavicle. And it happens by mechanism of injury is pooch, which stands for
Falling line outstretched line.
yeah, falling line outstretched. And then clear indication is deformity, swelling, point tenderness, and then to manage it, put in a sling, immobilization, and then in class we said the internal fix was best, like surgery using pins.
That's because that's fitted
Yeah.
in.
But it reduces the risk of re-injury, so that's why it's good. But basically, if you suspect a fracture, you're automatically going to immobilize it. Just immobilize. I think on the last test, there was like the whole like sprained ankle, point tenderness on the lateral malleolus, and he was looking for like immobilize and transfer, and like 5 people put that, I think. I was like, man, they're not getting the answer that you're looking for, because you were mostly going for like rest and stuff like that. So if you suspect a fracture at all, then immobilize it. Okay. Humeral fracture, most common in little kids. Their bones are growing. Also, mechanism of injury is falling on outstretched hand, and they obviously won't be able to move their arm, and since it's a fracture, you're going to splint it and transport it.
Question.
Yes.
So there are like a lot of injuries in this test, and a lot of them have like similar like what are the signs that there's something wrong and like what you should do and stuff. Like I'm just curious, like do we really need to make sure that like for in comparison to like a humeral fracture and a clavicle fracture that like know the differences between like they can't use their arm versus, you know what I mean? Like how in depth you need to know about stuff like that?
And stuff?
Yeah.
I don't think you're gonna have to like compare them, and so if you just, I mean, it's a fracture, so if you know symptoms of a fracture,
Then you should be fine.
Then you should be fine. And with things like this, like if they break their arm, obviously they're not going to be able to move their arm, and if they break their clavicle, like if you just think about it, like he said they like tend to lean towards the side of the broken clavicle. So a lot of them are,
Just self-explanatory.
yeah.
Okay, cool.
He did say there was more multiple choice in this test too.
Yeah, so there's more multiple choice.
So
So I looked at the test from last semester, the test that I took. Was that last semester? Yeah, it was all the way in January then. So winter semester, and he's gonna change it because there's some stuff on there that you guys need to go over in class that's on it. So obviously can't test you about it. And so, but there is a like good majority of multiple choice.
so second say just kind of be familiar with them enough to be able to recognize the difference between different injuries and like spot symptoms as a second injury.
Yes, but there, that being said, there also is short answer. So if it says like list the symptoms of whatever, then you have to be able to do it. Okay, so sternoclavicular sprain. So where is the sternoclavicular ligament? Yeah, it's right here between the sternum and the clavicle. So what causes it is a blow to the sternum and then torsion with posterior arm extension. So what does that look like? Yeah, it looks like this. Okay. So your arm is posterior and then you're being like twisted the opposite way. And it's gonna sprain that. Or if someone hits your sternum. So there's 3 grades. Grade 1 is little pain, no deformity. And then grade 2 is usually associated with a subluxation. And then you're not going to be able to abduct and adduct your shoulder. And then grade 3 is a dislocation and you can't move at like your shoulder at all. And there's a gross deformity. And then management, you just immobilize it. Use rice and recondition it to strengthen it. And then obviously, yeah, if it's serious, then we have to get surgery.
Alright, so this might sound kind of dumb, but how is it acting on the shoulder if it's like all over here? I don't know. It seems.
Well, when you move your shoulder, right, your clavicle rotates.
That's what I'm
And so if we abduct it, then it's going to be a lot of pain. So it's not like you're going to try and your muscles
Okay.
won't let you. It's going to be,
Okay,
you're going to
gotcha.
try and you're going to have intense pain, so you're not going to want to.
Got it. So that's the cannot. It's not the.
It's
Like,
not
it's not
physically
working to allow
cannot,
it,
yeah.
it's the
It's
pain.
just like you're going to have a lot of pain abducting.
That makes sense.
Okay, so AC joint sprain. Separated shoulder, so you have like a bump on your shoulder. It looks kind of weird. This is caused, it's also caused by Fuchs, but the most common mechanism of injury is direct impact to the tip of the shoulder, right? Because your AC joint is from your acromion to your coracoid process, and so if you have a direct impact to that, then you'll sprain it. So that's the most common mechanism of injury. I would know that over Fuchs. And then 3 grades again. First grade is stretched ligaments, point tenderness. Grade 2, the AC ligament is torn, and the coracoid ligaments. So there are 2. It's the conoid and the trapezoid ligament. I don't know if you have to know that in this class, but those are stretched. So they're not torn, just stretched. And then again, no abduction or adduction. And then grade 3 is all those ligaments are torn. So your AC ligament, your conoid and trapezoid ligaments, and then also no abduction.
So if on the last exam there was like a question in the differences or something like that, and if we had just said it was slightly torn or completely torn, it was marked wrong. So what was it the answer that we were looking at?
So the reason that he said to mark it wrong was because it was a symptom. He asked for a sign or a symptom. And so since that's not a symptom, it's like a characteristic, but you can't look at it and say, oh, your ligament's torn. Because you have to go around and see it. So because it's not a symptom, I know it's kind of a tricky question, but yeah.
The symptom would be like no adduction, abduction.
Yeah.
So then,
it'd be kind of hard to differentiate between grade 2 and 3 sprain without a
There's gonna be like an more intense pain.
Yeah, but
He
more or
also
less,
doesn't really like that answer, but
more or less the symptoms are the same for 2 and 3.
And on the last test, he didn't have us distinguish between 2 and 3. It was 1 and 2.
okay. So dislocation and subluxation, we already talked about this. Temporary displacement versus necessary reduction. So should you reduce a dislocation? No, right. You're not trained to do that. Professional needs to do it. So anterior displacement is most common. And this is also caused by direct impact or falling on an outstretched hand. And then you'll hear or feel a pop or a tear. And what's the tear? It says right there. So if you feel a tear, then it's most likely a Bankart lesion will form, and that's the tear of the anterior inferior glenoid labrum. And then you'll feel intense pain. And if you don't have surgery, sometimes they do surgery to tighten up the shoulder joint. I think he said that, at least he told my class, that they usually do it in younger kids so that they have reduced risk of re-injury. But they'll do a surgery to tighten the ligaments up. But if you do non-surgical treatment, then you'll